Hello everyone, good afternoon and welcome to the next module of the online course from MPS Europe, the Metabolic European Reference Network, MetaBRN, and Excellence in Pediatrics. I apologise you can't see my face. My name is Simon Jones. I have a camera issue, but I'm presenting this module. If you go to the next slide, please, Jane, with Jane Roberts, one of the clinical nurse specialists at Manchester Children's Hospital. I'm Simon Jones, a paediatrician here at the Children's Hospital. The topic of Module 3 is the role of paediatricians and managing the patient with mucopolysaccharidosis with their everyday health issues and as part of an MDT. So as I said, I'm Simon Jones. I lead the lysosomal storage diseases team here in Manchester in the UK. And Jane?
Yeah, I'm Jane Roberts. I'm one of the clinical nurse specialists up in Manchester, and I've looked after children with various MPS diseases for the last 19 years and work very closely with Simon.
Thanks. Next slide, please.
So I'm just going to do a bit of housekeeping. If it's your first webinar, can you not please take any screenshots of the presentations, and then do not reproduce any of these slides or the contents or the images that are on the presentations without the express written permission of the speakers. The format is going to take about 30 minutes with a short presentation, discussion and question answers. So if you want to ask a question at any time, just please submit them throughout the presentation via the question panel. You can only submit them by text. That's the only way you can do it, but not verbally. And at the end of the session, we'll try and answer as many questions as possible. And at the end, if you want to see it again for any reason, there's a recorded webinar available online at www.ineip.org.
Good. So today we're going to, as we said, try and cover the role of paediatricians. Although we don't know everything about all of you, and each country in Europe has a different healthcare system, we'll try and be as generic as we can and allow this to be as useful as we can to you. We obviously are based in the UK, where there's a very centralized healthcare system which does lend itself to the care of children with rare diseases by sort of mandating referrals through to specialist centres, where people like us, for example, we work in Manchester and look after children with MPS from the almost half of the UK, so certainly the whole north of England and beyond. And so there are local paediatricians working in the closest hospital to the family, and some care is provided there and some care is provided at our hospital, but our hospital may be several hundred miles from where the family live. And so although we are very much coordinating the care, they may need extensive local services from their local hospital and paediatricians. And so I think while this may be different in different healthcare systems, there may be, for example, in some countries in Europe, a very decentralized system. The same principles, I think, about how to coordinate care, how to look after these children and families and young people with very complex conditions, I think will hold true. And so irrespective of your setting and where you find yourselves, if you're looking after a patient with MPS, then I think there are several core messages that we'd like to stress here in the objectives. All of these patients, for reasons that should become obvious, will need a multidisciplinary or MDT approach to managing their healthcare. None of us can do everything. We need to think about the role of the paediatrician or the pediatric services closest to home in helping manage some of the aspects of these patients, and then to talk about how we try and make this work for the family and for everybody, and really having the family and the child at the center of this sort of care. So we'll try and cover all of this, and we'll use a case study to try and amplify and illustrate some of these. Jane, if you can move forward. Thanks. Excellent. So I hope that many of you will have attended some of the previous webinars, and if you have, then you will know all of this. I'll just briefly wanted to use this slide just to illustrate that there are multiple different MPS diseases, that defects in the MPS genes mean that there's a deficiency of an enzyme, which means that there is storage of these molecules that we call variously MPS chemicals, mucopolysaccharides, or GAGs, glycosaminoglycans. And these molecules, dermatan, heparan, and keratan sulfate, build up in tissues and progressively cause multi-system progressive dysfunction in our patients and families, in our patients and young people, causing the complex and varied diseases that MPS are. That those diseases that we see that have primarily a heparan sulfate storage, like Sanfilippo, for example, or MPS 3, give rise to a progressive neurodegenerative disease with all of the complications and issues that we have there, whereas defects more associated with dermatan sulfate or DS storage primarily give the progressive skeletal, visceral, heart and airway diseases that again need complex multi-system support. If you have diseases, of course, like MPS 1 and 2, where you have dermatan and heparan sulfate storage, then you need both neurological support and somatic visceral support. So these patients really stretch all of us as far as our medicine can go as individual healthcare practitioners, but also our healthcare systems and how good our specialists are. So I've spent much of the last 15 years of my working life looking after patients with MPS, but I recognize that the bit that I can do is probably, as an individual, is probably 5%. And as Jane might say later on, that's probably over again and over influencing my influence and direct involvement. So we need to be part of a team. It's not a choice in MPS, and that team needs to function well. So next slide, please, Jane. As you see, the team in this presentation involves the fact that I can't even advance my slides, and Jane has to do it for me. So really, what do we all need to do to look after these patients? So I've shown in the last slide enzymes and GAGs and genes, but actually it's about children, young people and families. And so we need support from early diagnosis of these conditions. And there's been previous webinars thinking about how we achieve accurate and timely diagnosis for these patients, but also managing throughout the disease, supporting the family through the shock of the diagnosis. And there are webinars about dealing with the psychological consequences of this, moving through to some of the major interventions, maybe orthopedic, and then also thinking about end stages of the disease. So that may be, from the point of view of us as a paediatric service, moving through to transition to adult metabolic or MPS care, but it may also be the end of life care that affects some of our MPS families. And whilst there is a very broad spectrum of how MPS affects patients, and increasingly we're aware of adult onset MPS, we do know that MPS is for many individuals with this group of diseases a life-limiting condition, and that the MPS disease will have a role to play in how long they live. And although our interventions, we hope, have dramatically increased, and in many cases we can prove that they've dramatically increased the lifespan of our patients, that is not yet for many of the individuals that we look after a normal healthy lifespan. We're really in this talk specifically not going to talk much about some of the what we often think of as the exciting advanced interventions such as enzyme therapy, bone marrow transplantation, or now increasingly genetic therapies. What we want to talk about is actually what Jane and I, spend the majority of our time doing, which is not delivering those fancy therapies, but actually doing what we think of as good old-fashioned proper clinical care. And it's really important to get right. So as we talked about, the MPS diseases are complex. They affect the majority of body systems, although each patient is different. Treatment, in terms of supportive treatment, requires very much a multidisciplinary approach. Often there needs to be a lead clinician or a lead center directing care, and that's not necessarily always a doctor. In the UK, we have the system that I've described earlier, but in other systems, healthcare systems, that will be different. But there still needs to be a centre that is coordinating care, even if things are very decentralised in your healthcare system in your country, even if surgery or one type of surgery is done at one institution, another transplant is done at another, or enzyme therapy is done at another. There needs to be someone or centre who takes control. Otherwise, we end up, as we've seen with a number of patients, risks that no one makes key decisions and the patient is in stasis and never moves on, or that everyone just makes their own decisions without regard or consequence of what any of the other institutions, centres and practitioners are doing, which can lead to sometimes some quite catastrophic results. So, and we've seen that. So there does need to be a way of coordinating care. And for your own healthcare system, you need to work out for each patient how that is going to be. From our perspective here in Manchester, we see every day that having an engaged, involved local paediatrician is really helpful to our patients and our families and to us, as many of our patients come from far away to our centre here in Manchester. And if they do come a reasonable distance, then having good healthcare to deliver acute healthcare, but also community and chronic involvement, healthcare involvement, can be so important, because there are a number of things that we can't do. We don't want to take over the role of a local paediatrician. There will be things clearly that a local paediatrician will be able to do better and much more in a much more easy and accessible way for the family than we can manage here in Manchester. And there were things, of course, that we will need to bring the child or family here for if they need a very specialised intervention, if they need a bone marrow transplant, if they need complex surgery, then they may well need to come here or to a hospital that can deliver that. But if they need routine healthcare, then there may be no reason why they can't have that very close to home, either delivered in the community or in a local hospital. It may be, of course, if one of these children has very, very challenging airways, then a very simple procedure, which maybe is performed every day in your local hospital, may be too dangerous for these patients. But having coordination and good communication allows these decisions to be made. Some of our patients, for example, will have a portacath or a line inserted at their local hospital, because we know from experience and having anaesthetized them before that they may have very good airways and their risks may be very close to that of a healthy child. Whereas for many of our children, that's just not possible or safe because they have very challenging airways, and their interventions, anaesthetic interventions, need to be very carefully planned with the most expert of anaesthetists. And so there may be only a very small number of places in the country where they can be anaesthetized safely. And this variability where within a patient and between patient means that we need to communicate and have a healthcare plan for each particular patient. This is a lot of work, and these patients are a lot of work, and I think we need to be open and honest about this. And all of this planning and work is actually essential to provide the best quality care and to keep our patients safe. And actually, if done well and done right, I think it's actually enjoyable, and I enjoy looking after our patients. And I think those paediatricians who we've worked with for many years, and particular children from diagnosis through to transition to adults, where they have been really involved, have in general really enjoyed that and found that that's been a useful experience for everybody. Okay, Jane. So I just before I hand over to Jane in the next slide or two, I just want to bring up this slide, and we've amplified the role or highlighted perhaps the local paediatrician here in this list, but I think this is Jane's slide originally. I've stolen it. And what I wanted to really show is the huge number of healthcare professionals that these children, young people and families have to deal with on an average week, month, year. And each of these, and in fact this list could even be longer. I mean, it's just a huge number of professionals and services that the family have to engage with, remember appointments for. Many of our families, if they tot up or count up their appointments over a year, will have 60 plus appointments with different healthcare professionals in an average year. That's more than one a week. And you've got to also do everything else that a parent does: school, try and have a life, feed everybody, go to the shops, survive. And a parent might actually have work as well on top of that. And I don't know how some of our families manage it. And so trying to coordinate all of this between ourselves as healthcare professionals, streamlining this as much as possible, has a huge impact on role, and can seriously improve the outcome of healthcare for the families. So, and finally, it's important to see the child, not just the disease. As somebody who spent a lot of their working time researching MPS and trying to develop new treatments, we think about gags, we think about chemicals, we think about cells, we think about tissues and organs, but actually there are different children and young people in very different, who are all affected differently by this group of varied conditions. They may all have their own genetic mutation, and they have their own backgrounds, their own healthcare backgrounds, their own social and family and cultural backgrounds. And so care doesn't need just to be thought of for these families in the context of their particular organ system, or how bad a heart valve or an airway is, but also in terms of where the family live, what else they're dealing and struggling with, and what the particular level of understanding and ability to cope with all of this is. And so tailoring our healthcare for their needs is critical. And we're in this for the long haul. We are always telling the families this is a marathon, not a sprint. And keeping these families on board and engaged with us and with healthcare for 10, 15, 20 plus years is incredibly important. And now we're handing them over to the care of our adult colleagues, and thinking about young adulthood, about work, and about having families themselves. So I think really putting the child and young person at the center of what we do for the long run is really so important. And we'll talk about a case now of a young man that Jane and I knew very well and worked with for many years, because I hope he illustrates some of this. Thanks, Jane.
Okay. So we're going to move on to this very short presentation, and I'm going to introduce you to Jack, who we looked after for very many years, and he was diagnosed with MPS 2, attenuated MPS 2, when he was 3 years old. He actually came on the original trial, and he had the placebo for a year, and then started enzyme replacement therapy when he was about 10. And this seemed to ameliorate some of his symptoms and slowed his disease progression. But over time, as he grew up and became a rum drinker and a smoker, and he craved his independence, got a job in the local pub, we were getting him ready to transition to adults. At this time, he started to run into some devastating airway problems, and we all know that having problematic airways is very devastating and causes the most common cause of death in our MPS 2 population. So Jack had multi-level airway issues, and sometimes we try and fix this by trying to take out the tonsils and adenoids, but when they tried to do this, they couldn't intubate him because he had the tick list of someone who can't intubate. He had a large tongue, excess secretions, rhinorrhea, severe tracheomalacia, everything that and down to obstructive airway disease and terrible sleep apnea. They did manage to do a bronchoscopy at one point, and it showed 90% collapse of his upper trachea, which is really devastating. Because he lived 200 miles away from our hospital in Manchester, it was really important he had local and specialist teams to support him and his family. And eventually, because Jack was such an amazing young adult and had a lot of life to live, it was decided to place a tracheostomy in him. We know this isn't a quick fix for the MPS 2 children, and it's not a routine op we take very lightly at all for MPS 2 children. And we had lots and lots of discussions regarding the risks versus the benefits of placing a tracheostomy, which was going to be permanent. You know, Jack had a massive bucket list, and his biggest desire was to go swimming in Barbados. So we had to involve our paediatricians. They were already involved. They looked after Jack locally for many years. And at this point in time, they were especially invaluable because we had a lot of pre-op care to organise, which could be done, you know, near his house, not 200 miles up the motorway. You know, it's really important we were going to keep him safe, so we did multiple sleep studies with him, and emotionally we had to support him. It was a massive undertaking he was going to endure, and so we had to have local psychological support, which was really helpful. Also, he loved going to his local hospice, which was a great place for him to just forget all his worries and enjoy some regular time with his mates. The community nurses were brilliant, and the paediatrician coordinated them to come in to do regular blood gases so we could keep an eye on what was going on overnight. And also we managed to get CTs of his trachea, you know, brought up through our PAC system, so everyone had a very good idea of what we were going to enter into. And of course, we needed these results relaying, and it worked very, very well. However, his tracheostomy was really, really challenging. He had an awake intubation, and the purpose-made tracheostomy tube that we had made for him was inappropriate and didn't fit. This is because he had very deep trachea and the cartilage were really thick. So our ENT surgeon had to think on his feet, and he ended up cutting down an ET tube and popping that in. But 24 hours later, this was failing. Jack was getting into a lot of distress, and again, he had to be rushed back to theatre and have a bigger tube put in. And actually, the ENT surgeon said he thinks he lost 10 years of his life doing that. It was so tricky. You know, post-op, he ran into complications with neck and head emphysema. The tracheostomy changes were very traumatic for him. A lot of bleeding, a lot of secretions, constant suctioning. This all settled eventually, and he was given a bespoke bivona, which came from America. And before he left, he got a T tube put in, which he learned to suction his own way with no gloves and one suction catheter at a time. But he learned to do it himself, which was really, really good. And without our local paediatricians supporting Jack, we would not have got him home in a timely manner at all. You know, when we send someone home with a tracheostomy, they need buckets loads of kit, you know, and they need support to access all the services. Plus they need oxygen supplies to the house, and oxygen, suddenly they become very medicalized. So it was very good that paediatricians could liaise with the family to do this. Jack, again, he's becoming a young man now, as you can see, his moustache has grown, and so he got referred to the adult hospice care, which he thoroughly enjoyed. And it was great because the communication was great all along the way, and any concerns, any worries, the paediatrician would come and just tell us about it. And this was great for the family. They felt really connected, they felt very in control of Jack's care, and they were really happy they could access and coordinate the local services themselves, and the confidence in the team grew immensely. So it's very obvious what some of the positives of local management is. A, they don't have to drive up on the motorway for many, many hours just for a sleep study. You know, they can get access easily to their local services for physio. They get help with education and one-to-one services. If they need antibiotics or any change in painkillers, that can be done locally without having to come here. And also, like Simon said, the team are able to pick up evolving problems so we don't get so many children in dire straits. For the local teams, you know, the paediatricians get to know this very rare disease. They may not want to, but they do get to know a lot about it. And with their relationship with the metabolic service, they can come and attend study days, they can come on conferences and build their knowledge and skills around this cohort of patients. Also, they become aware of what procedures they can do and what procedures they shouldn't touch, and they are very aware that a general anaesthetic should not be taken lightly because of the disease restrictions. And we know working together can allow teams to become more creative with the solutions to MPS problems, and also, again, it helps to spread awareness in the community. So where there's a positive, there's always a negative. I mean, our families, we do wrap them up sometimes in cotton wool. We're quite bad at handing them over to people, and we need to be better at referring these children to a paediatrician when they get diagnosed, so they can get to know them, the family know who's to contact. Although some of the families can be resistant to change and can be resistant to engaging with other services. So it works the way sometimes the local team doesn't know who to contact, so you know, there can be delays in results. So it's really important we get the communication sorted at the beginning. Trust needs to be grown. These patients are very well informed. You'll find that they have a lot of support, a lot of education, a lot of information given to them, and they are very informative families. So they need to grow their trust in the local services. And the local services in themselves have to grow in trust and confidence in dealing in these quite challenging families with a lot of problems. And they become more confident if they see them on a regular basis. We know that MPS is a very rare and complicated disease, but actually paediatricians have a vast array of skills in their hands. You know, a lot of the problems that they present with are sometimes like an ear infection or pain management, or they might have fallen on their bike and broken an arm, so they all have normal bumps in nature as well. Surgery, again, please discuss with the specialist centre just in case there is something outstanding that we haven't communicated. Coordination of care, we need to be really careful we don't over investigate, give them so many appointments that they don't attend and become appointment fatigued. Again, we've seen that very large team they've got. We're going to add some more people in, and the people and families do get muddled up sometimes. So it's very important we try and keep it tight. And of course, having a nurse specialist, I think, is very useful, and I hope Simon agrees.
Of course.
So in summary, we know communication is really important. It's key that we keep each other informed. The coordination of care is vital. We spend a lot of time talking to our local service, our local paediatricians, and keeping everybody doing the same thing. Knowledge and education spreads disease awareness, and doing this, we help raise standards of care. We need to respect each other's skills. It's not a competition between the teams. We really do appreciate everything our colleagues do locally, and it's a shared experience. And having this joined up thinking increases the quality of care for the patients, and also gives them more choice for them in the long term. Also, we need paediatricians to be part of our team, especially now COVID has shrunk our world so much and it's a lot smaller, and so we really need our colleagues. They're really valuable and we really appreciate them. So thank you for your time, and Jack's family for letting us use their photographs, and here he is having his swim in Barbados. Any questions? So one of the questions we have put up on the slide is, what are the particular challenges do paediatricians face when looking after an MPS patient? I'm not sure if anybody's had any particular challenges. I know we have, haven't we, Simon?
Absolutely. I think, yeah, I mean, I just to reiterate, I think what we said earlier, I think we can see that where there's an engaged local paediatrician working as part of that multidisciplinary team, our patients, our families get better care, and they become the local coordinator in many ways. Yeah, we have some occupational therapists and speech therapists and physiotherapists at our centre, but you know, the families will need those allied healthcare professionals close to home to manage things in the community or a local hospital, depending on your country setup, and liaising, coordinating with them, making sure that the particular needs of MPS patients are met can be very challenging. If the local paediatrician has a good relationship with those healthcare professionals, then that makes life for the families much better, because the type of management we think our families need is quite different from a lot of children, and many of these services, certainly in the UK, are based around children with sort of static neurodisability or musculoskeletal problems, so I think what our MPS families need is actually not quite that, but something that is a bit different and with different expectations. And so managing that with lots of communication and education is, I think, important.
Okay, so we've just had a quick question. Can you see the question, Simon?
Yep, do you want me to read that? Yeah, so can the general practitioner or GP play a central role in coordinating and following up and trying to make a link between the university hospital to push forward some items in care, especially when the neurologist of the university hospital doesn't do much coordinating and follow up, especially for patients who are in adulthood and too old for a paediatrician. And in transition, the GP can maybe be a good doctor to follow up in the neighbourhood, how to make this work. Yeah, so I think this is a really big issue, especially when we think about transition of our young people through to adulthood. There are roles certainly that the paediatricians have traditionally played in managing children with complex needs, that are primarily that of, as you say, coordinating care, linking between services, managing education, schools, etc. And that much of those roles do not exist in some ways in secondary care in adults. There is no, often, certainly in the UK, there's no general physician anymore. And so in some countries, the specialist, if you like, who may be a neurologist or something else, will view themselves as having a limited role, limited to one organ system or to specific issues or an overall direction of care, and therefore there's nobody actually coordinating care, and someone has to do that. You're absolutely right, and that's kind of what I was saying earlier on, in that I think in each healthcare system you have to decide how to make this work. The healthcare system that you describe, very different from ours, but it can still work as long as someone is doing that coordinating role. And if it's not going to be the university hospital, then it needs to be someone else, and it may be the GP, especially if the young person, the young adult, is beyond pediatrics and there's no one else doing that role. And if you or the GP can take up some of that role, making sure that everyone's talking to everyone else, and the needs of the young adult are kept paramount, and communication with them is good, and they are also part of the whole team and part of the decision making, then I think that can work equally well. So there's no perfect system and perfect way to do it. You have to make it work in the system that you work in, because our healthcare systems are not designed for MPS patients. They're designed for much of the other much commoner typical healthcare needs. So we have to make our own system work for MPS patients. Does that sound reasonable?
Yeah.
Would you agree, Jane?
Absolutely. You just need good coordination and people to make sure the patients are safe at the same time.
Yep. Another question is with regards to immunizations and vaccinations for MPS patients. We are very strong in saying that all of our patients should be fully vaccinated according to each country's schedule. Where there's recurrent infections, we'll often check to make sure that there's been immunity against particular vaccinations, particularly the pneumococcus, and sometimes our patients have had to have boosters. That's not because MPS patients have a particular problem with their immune system. It's just because they're much more at risk of recurrent infections because of the function and structure of their airways and ENT aspects, for example. Our bone marrow transplanted MPS patients have very specific vaccination and immunization needs, but once again, it's very important that they are protected and revaccinated following transplant. But the transplant teams will usually guide that in particular. So there's nothing that we avoid completely, and we are very supportive of vaccination. The next question is about common kidney or urinary tract involvement of the disease, which is a good question, and you've selected, I think, probably the only organ system that isn't particularly involved in MPS diseases. We know there's a lot of storage in the kidney. If you look at biopsies or autopsy samples from our MPS patients, there's storage in multiple parts of the kidney, particularly in the tubules, but there doesn't seem to be a progressive or renal disease that we find. A few of our patients have hypertension, although the etiology of that is hard to know. We, of course, measure outcomes of treatment and diagnose our patients by the urinary glycosaminoglycans, which probably reflect tubular storage of GAGs, which is, again, somewhat ironic given that we've just said it's the least involved organ system in the patient's body. But yes, I hope that answers the question. You've picked the easy organ system.
That's a good question. I didn't realise all the questions were dropping down. Yeah, so which is a very early symptom that the paediatrician will alert to investigate the child for MPS and have so earlier pickups of patients? That's a really good question, and it's something it's really important to be spreading awareness out there. And there's a lots of literature now about the red flags that the children present with. And what do you think the most common one is, Simon? I think it is ear infections, hernias. What do you think?
Yeah, I mean, certainly in the first year of life, it's typically sort of relatively soft signs like recurrent ear infections, glue ear, a bit of hearing loss, recurrent rhinorrhea or persistent rhinorrhea, with the speech delay associated with conductive hearing loss. Then there's often not there are often not growth issues in the first 2 or 3 years of life. There may be hernias sometimes very early on, mightn't there? And some of our patients fail newborn hearing screening tests, but MPS is not typically, at least in the UK, part of the battery of tests that you get tested for if you fail your newborn hearing screening. So whilst there are often very early signs for most of our patients, often patients are not diagnosed at that point because there are lots of other causes for ear infections and hernias and those sorts of things. But often it is the generalist rather than the specialist who makes the diagnosis, because it's not the ear infection or the hernia that will give away the diagnosis. It's the combination of those. So that often requires the generalist or the GP or the paediatrician who can step back and look a bit at everything. Yeah. That is the one who's able to put the pieces of the jigsaw together.
Yeah, and often you sometimes have the children here, they're already under 4 or 5 specialists and they're 18 months old, which to us is a bit of a red flag as well.
Okay, I think we're out of time, beyond our time, and thank you very much, and I apologise, although not too much, for you not being able to see me. It's not a great loss for you, but you have been able to see Jane, who's now holding up a picture of me, and thank you for attending and interacting, and I hope it's been useful. Thank you, Jane.
Thanks, Simon. See you again. Bye.